and thank you for joining us for today's International Myeloma Workshop Daily Update. I'm Mary DeRome, Director of Medical Communications and Education at the Multiple Myeloma Research Foundation, and I'm here in Vienna for day 2 of the IMW. Just for those viewers who are thinking about our COVID safety, I wanted to let everyone know that here at the conference, where we are live, everyone has to be fully vaccinated to attend the conference, and we are all tested daily for COVID-19. Today, I'm joined by Dr. Irene Ghobrial from the Dana-Farber Cancer Institute in Boston, Massachusetts, and Dr. Cesar Rodriguez from the Icahn School of Medicine at Mount Sinai Hospital in New York City. Most of the questions that we receive at the MMRF have to do with immunotherapy, and it was the focus of today's main oral abstract sessions at the IMW. Irene, as you can imagine, CAR-T is a really hot topic among our audience, especially since the FDA approved the first CAR-T cell therapy, Abecma, just a few short months ago for myeloma patients. So can you tell me a little bit more about Abecma? For example, who is eligible to receive that therapy, and what risks might be involved with treatment?
Yeah, absolutely. And it is indeed an exciting time right now for immunotherapy. As we know, there is a huge understanding of why the immune system is so important for us and how it can really attack the cancer cells. And it's a completely new way of thinking for us for multiple myeloma therapy. So it's a new era for us, and we're very excited about it. In general, and again, the numbers will change and the indications will change. Right now, it's for the relapsed refractory multiple myeloma after you've had multiple other lines and after you've tried other agents already. Daratumumab, immunotherapy, or immunomodulators, proteasome inhibitors, and so on. However, we know that that will change and we will get it earlier and earlier. And indeed, we have clinical trials right now to bring CAR-T therapy as early as newly diagnosed myeloma and potentially even in smoldering setting, which is my area of interest.
That will be very exciting when that happens. And I'm sure that we will get to that point. So, Cesar, I'm going to turn to you for the next to be approved CAR-T therapy, which is Silacell. So we saw a presentation on that today. Really exciting data. What can you tell us about that compound?
Sure. So Silacell is just like the other CAR-T that got approved, also targeting the same part of the myeloma cell, the BCMA. It's just constructed a different way. And there were 2 studies that were presented today from that particular drug, Silacell. CARTITUDE-1, which was an update of what has been presented in the past. Before it was presented all the data up to 12 months follow-up, medium follow-up. Now it was presented on average up to 18 months or a year and a half. And the data continues to be very, very promising. 97% of the patients who received Silacell were having a response, and out of those, they were achieving a stringent complete response, which means that there's no detectable disease in the blood, and when the bone marrow biopsy is done, the pathologist does not find any myeloma.
And that's just from one treatment?
That's just from one infusion. Mm-hmm. Now, the interesting thing of this update, it's 1.5 year on average follow-up, is that the people who did achieve a response and continued to be in response achieved a deeper response. And now we're seeing that 80% of the patients who are responding are actually now MRD negative. In the previous presentation of this data, it was about 70%, 70 to 75%. So we're having deeper responses that are ongoing with this. Now, this is a study, the CARTITUDE-1, that was people who had at least 3 prior lines of therapy. They presented another study, which is CARTITUDE-2, and CARTITUDE-2 has different arms. One of the arms is giving this treatment a little bit more upfront, like Irene was mentioning. We definitely want to do this earlier on in therapy and earlier on in hopefully a diagnosis or when we're just starting to see the myeloma come up. So CARTITUDE-2, one of the arms is focusing on people who have had 1 to 3 prior lines of therapy. Mm-hmm. And in this arm, it's very early. It hasn't been even a year from when it started, but 20 patients have been enrolled. And the responses that we're seeing are very similar. 97% response rates. Toxicities are very similar to what the previous studies have shown. So that's very exciting, and hopefully this will pave the way to earlier treatment instead of having to wait to more than 4 prior lines of therapy, which is what's approved at this moment with the Icahn. So hopefully before the end of the year, we'll have this other therapy approved based on all this data.
Did they present overall survival data for Silacell at this presentation today?
No, they did not. It's not long enough. The data is not mature enough. So we'll have to wait a little bit more.
I did find it interesting that Dr. Anderson, during the Icahn presentation, talked about the overall survival being almost 25 months now. That's how long they've been able to carry that therapy out, and it was almost as long for patients who had high-risk myeloma. So it really is a very, very promising area of therapeutics for myeloma patients for sure. These CAR T cells, it's amazing. So another immunotherapy that really elicits a lot of questions from our patient audience is the bispecific antibodies, and that's just like the word on everybody's lips these days, right? So Cesar, can you tell us what makes a bispecific antibody different from a CAR T therapy or different from the monoclonal antibodies that are already approved, like Darzalex or Sarclisa? And then can you tell us about which bispecific antibodies were discussed today? We heard about talquetamab and then also elranatamab, right? So, and then talk a little bit about those and some of the data that was shown in the presentations.
All of these therapies are immunotherapies, which means that they use the immune system to try to attack the myeloma cells. And the difference between bispecifics and the current antibody therapies like daratumumab or cetuximab is that daratumumab and cetuximab is just an antibody that goes and binds to the myeloma cell and triggers its destruction or does a chain of events that help it destroy it. Bispecific, I want you guys to picture an antibody that has 2 arms. And it's going to grab the myeloma cell from one arm, and it's going to grab the immune cells or the T cells from the other arm. And once it has both grabbed by the hands, then it's going to activate it to destroy the myeloma cell. So it's a more directed therapy. And the reason why we want to do this is because a lot of the times the myeloma cells tend to camouflage themselves from the immune cells, and they can't see where the cancer cells are. So that's the nice thing about bispecifics. And then with CAR T, it's a little bit different because we're engineering and teaching the immune cells, the T cells, exactly how to go and destroy. So we're making them like stealth killers for myeloma in particular. Now, there were 2 different types of bispecifics that were discussed today. One of them is the talquetamab. And the talquetamab is a bispecific that binds on one part to the T cell and the other part to a different surface marker of the myeloma cells. We're very used to hearing BCMA, and there's a lot of studies with BCMA, but this bispecific in particular binds to a different marker in the myeloma cell, which is called GPRC5D.
It's a mouthful. Yes.
So why is this important? So they've already done 184 patients who've received this therapy. Out of those, 80 of them have received it as a subcutaneous injection, the rest IV. And the response rates were very good. Overall response rates were 70%. They were very well tolerated. There were very little grade 3 toxicities from it, CRS toxicities. And the important thing about this is that it gives us an alternative to a BCMA immunotherapy. So we can use something different, or we can use this as a rescue if we are seeing people relapse on BCMA, which is very, very, very unique. And people who were on this study, there was a number of patients who did receive prior BCMA, and they did show responses. So that's a very promising thing. Elranatamab, which is another bispecific. We have to learn how to use.
I know. We're all learning.
Exactly. It targets BCMA, just like a lot of the other bispecifics that we're being studying in clinical trials and CAR T therapy. And the unique thing about this particular bispecific therapy or this clinical trial is that they did include patients who had been exposed to BCMA before. They've only had 4 patients, but out of those, 3 of them did respond. Which is very promising because a lot of the question that patients have is, if I receive a BCMA targeted therapy, whether it be an antibody drug conjugate or a bispecific or a CAR T, and relapse, is that out of the equation now or not? And this therapy and this clinical trial is showing that it's not necessarily out of the equation. We could potentially still target that same surface marker, just attack it from a different angle so that we can have some benefit from it. And the response rates with this bispecific that targets BCMA was 84% overall response rate. So very promising data. And all of these two bispecifics have the unique quality that they did include patients that had BCMA therapy in the past.
That's really almost a new classification of patients, right? We've talked for a long time about patients who are triple class refractory, right? So they're refractory to the proteasome inhibitors, to the IMiDs, and also to the CD38 monoclonal antibodies. And now the fourth class is the BCMA targeted agents, right? So those are the quad refractory patients. I think somebody said that we need to find a better word, but
Yeah,
we'll see about that. But I thought that was really such really interesting data. So Irene, now we're going to turn to your pet projects of Smoldering and Precursor Conditions, right? So on Wednesday, when you were not at the meeting, but you were still virtual, you presented a plenary session on screening for precursor conditions. So can you walk us through a little bit about what a precursor condition is and what that means? Do you think that all patients should be screened, or all people should be screened, like the way that people are screened for colon cancer now? And really, what are the ramifications of that?
Yeah, so if we think about how we diagnose our patients right now with multiple myeloma, people are usually coming in because they had symptoms. They had bone pain, they had fractures, they had anemia, and then they see their doctor, then they get the diagnosis of myeloma. And it's a disturbing thing because suddenly your life is changing when you're diagnosed with this. But what if you change that? What if we actively look for surveillance and try to find, if you have that precursor condition for myeloma, find it early, especially if you're high risk for it, and then prevent it from happening, prevent myeloma from happening to start with. And if you think about it, for many other cancers like breast cancer, colon cancer, we are doing cancer screening because cancer screening saves lives, and that's important. So when you're age 40 or 50, you start doing your cancer screening because you want to detect it early and prevent it from going all the way to breast cancer metastasis or to colon cancer metastasis. And by diagnosing it early and intercepting early, you can make a difference in the survival. That's what we want in multiple myeloma. We want to change the way we think completely. And we know now that for smoldering myeloma, you can treat early and make a difference, at least prevent end organ damage. That's the least hanging, the lowest hanging fruit that we have. So for you to be incidentally found with smoldering myeloma, that's not good enough because one person may be diagnosed early and another person not. And what we're doing now with the PROMISE study, as well as the iSTOP study in Iceland, is we are screening, at least for the PROMISE study in the United States, we're screening high-risk individuals, meaning you're at risk of developing myeloma, but you don't know it yet. And this is either you're African American or you're of African descent, or you have a first-degree relative with multiple myeloma or other blood cancers. And we know that if we look at the general population, the risk is actually much lower than what we find in the high-risk population. So the general population has about a 3% chance of developing MGUS, which is the early precursor of myeloma, by age 50. That's not a huge number. But once we start looking at the high-risk individuals, now it's up to 10, 15%. That's a huge number of people who we can save if we diagnose them early. Now, the other thing that people say, well, I don't want to know that I have MGUS because I'm going to be worried, I'm going to have problems thinking about it all my life. And think of the reverse. Would you rather know that you have that precursor condition and you make sure that you prevent it from going all the way to myeloma versus suddenly showing up to your doctor and knowing that you have active myeloma, active disease? And that difference of I am in control of my potential progression and I can do something about it. And if there is nothing, it's not progressing, I'll watch it carefully once a year, go see my doctor. And if it's not, if it is progressing, I now can do something about it and intervene. And my hope for all of us is we will never develop myeloma, active myeloma. We will never have a patient come to us incidentally found with multiple myeloma.
And you did, part of your study was actually to survey patients to see how they really felt about getting that news and whether it really bothered them knowing. And you found out that that it didn't make a difference to them, right? Knowing or not knowing, they basically felt the same.
Exactly. And I can tell you a lot of my patients, because we call everyone when they're positive and we tell them and we ask them that question, they say, sometimes they tell me, I'm relieved. I know now what to expect and what to do about it. And many of them are relatives of someone. My father had myeloma, my mother had myeloma. I want to know if I have that early condition and prevent it. And as we were talking about immunotherapy, that's the new era we're bringing in for smoldering myeloma. We're changing the way we think that in the future we will not be treating with conventional therapy. We will be treating with immunotherapy early and upfront.
Yeah. And some of these immunotherapies are so effective and they're so non-toxic. And I know that there are already trials ongoing for high-risk smoldering patients using some of these monoclonal antibodies and getting some really interesting results. So we'll look forward to seeing some more results from those trials as they become more mature. So that's really exciting data. So also there was a session today, Irene, which included some data on risk assessment of smoldering multiple myeloma. So as you know, many of our audience watching that have smoldering myeloma, and they always ask whether or not they can be treated. And we had a webinar not too long ago about this, and many patients were asking that question. And I know that is true, but treatment is possible, correct? And especially for patients who are high risk smoldering myeloma. So can you talk to us a little bit about that risk assessment and how it's helpful in making the decision of whether or not smoldering patients should be treated?
Once we have more than 10% plasma cells or cancer cells in the bone marrow, we call that smoldering myeloma. But that's a huge number of people who are either very slowly going to get myeloma, MGUS-like, and they may never progress to myeloma, or some of them are going to progress very fast to active myeloma within the next 2 years, what we call high-risk smoldering myeloma. The problem is it's hard to differentiate. It's hard for me to predict well who will progress and who will not. So we try to grasp on things that can help us predict the future. And you think of it, it's more like the Weather Channel and the person who's predicting the hurricane is coming in. They're not sure 100%. Exactly. So you're trying to have data in your hand to help you decide who will truly progress in 2 years from now. Some of the data is clinical data, what we call 20% plasma cells in the bone marrow, 2 grams protein in the blood, 20 light chain ratio. This is what we call the 22-20 model. That's a clinical model that helps us because it's easy to look at. But it's not enough because it gives me a 50% chance of progression in 2 years. That's like flipping a coin. 50% I'm going to progress, 50% I'm not going to progress. So can I improve on it? Can I give you a little bit more assurance whether you are truly going to progress in the next 2 years and you should do something about it, or maybe not. Maybe you're in the 30%, 20%. Let's watch you more carefully. Or let's wait for the next therapeutic option so that you don't have to now make a decision on therapy. And that's such an important point because you're making a decision, do I get treated now or 2 years, 3 years from now? Should I use this therapy or think about something else? It's a big decision. We spend hours talking about whether I should make that decision or not. And what we're now finding is we can add to 22-20. We can add to the to the clinical factors by adding genomic factors. So MAP kinase mutations, MYC amplification, translocation, all of those. And it's not that hard to get next generation sequencing. It's not that hard to get FISH and other data to get information. We can add dynamic factors, meaning your M spike is going up, your light chains are going up, your hemoglobin is dropping. That's very important because it tells me that the myeloma cells are already moving. They're already changing their dynamics. We can add circulating tumor cells, which is what Bruno and the Spanish group has shown us today, that indeed when I look at your blood, I can detect more information that can help me understand and predict better. And we're also developing immune biomarkers that tell us if someone's immune system is changing, and that can predict that they will go to myeloma or not sooner, or should I also use immunotherapy for them? So it's not only predictive of progression, it's also predictive of what option of therapy I'm going to use in the future, which is what we call precision interception.
This is all just really such fantastic news for patients who have smoldering myeloma or even MGUS, that we're making so much progress in this area right now. And for a long time, there really was no progress, right? It was just, you basically just had to watch and wait and see what happened. But now we're really moving forward with a lot of really effective therapies for these high-risk patients in smoldering in particular. So really very hopeful for patients. So now I'm going to go to our final topic, which is the topic on everyone's mind, which is COVID-19. So there is a very hot topic, and there was a session today on COVID-19. So patients want to know how myeloma patients have fared with the vaccines, without the vaccines, with COVID, what has happened. And so I wanted to get some information from you guys about, and I'm going to start with you, Cesar, because I know there's been a lot of work in myeloma with COVID, particularly at Mount Sinai. So I wanted to find out from you, like, what type of work has been done that has come out of Mount Sinai with myeloma and COVID-19? And, maybe what are the common questions that patients would ask you, and what would you tell them?
So yes, unfortunately, Mount Sinai was a big hub for COVID during the peak of the pandemic. And we are presenting a poster. One of our colleagues, Oliver, is presenting a poster on that data at the meeting today. And it is the most common questions that people ask who have multiple myeloma during the pandemic are, should I get the vaccine? Is the vaccine going to be effective? And how do I time the vaccine with treatment? Can I continue therapy while I'm getting the vaccine or not? And what we've been doing at Mount Sinai is we have been following all of our patients with myeloma, encouraging to get vaccinated, and then monitoring antibody titers to see if they are mounting a response or not. One of the problems with vaccines is that we need to have a healthy immune system in order to mount a response to that vaccine. And that's a good example of that is whenever we get a bone marrow transplant, we tend to delay revaccination and all of our immunization from when we were kids because our immune system is not strong enough to mount the response. Well, a similar situation is happening with the COVID vaccine. In myeloma, patients who have their immune system very compromised might not mount that same response as healthy people and are not going to have that same protection. So they still need to have some caution as to what they can and cannot do. And what we're telling patients are to continue to be safe, even though they've had the vaccine, to try to avoid large crowds, to try to continue to wear a mask as much as possible. Yes, you cannot stay in a bubble the rest of your lives, or at least through the whole pandemic, but we still need to be cautious. And what the CDC says, that people who have been vaccinated, they can freely hang out without having to wear a mask in an enclosed area. We could still do that as myeloma patients, but be a little bit safer and not risk it too much, and try to use the mask if it's possible so that we can try to prevent that. Now, we have been doing some studies, and we have seen that there are certain particular agents that do affect the efficacy of the vaccine. In particular, daratumumab is one of those agents that definitely affects how the antibody titers are. So what we've been doing is we've been holding a cycle of therapy so they can get the vaccine, and then delaying the reintroduction of antibody therapy or immunotherapy a month so that the vaccine does work. There are other agents like immune modulators or proteasome inhibitors where we're not necessarily holding, and then alkylators we're holding for about a week before or after to try to make sure we get the best bang for our buck when it comes to the vaccine. And then in terms of the booster, which is now a thing in the United States, and the CDC is recommending that booster shots be given at least 8 months from the last vaccine. We are encouraging a booster shot in patients who have received either the Moderna or the Pfizer vaccine. We still don't have information about the J&J yet. We're waiting to hear from studies that are ongoing, and hopefully we'll have more information about that, because it does cause some anxiety for patients who did receive the J&J. Why do other patients get to get a booster and we don't? Well, we need to wait to get that information before we can encourage others who got the J&J to get a booster shot. So in the meantime, continue to be safe, continue to wear a mask as much as possible, continue to try to stay away from large crowds or large enclosed groups of events until we have more information. And hopefully we will be done with this soon.
Hopefully, can only hope. Is there any data on how many myeloma patients who may have been vaccinated and really didn't mount a response to the vaccine?
There is, that data will be presented at ASH, hopefully,
okay.
Yes. And there is some data that is showing that a larger percent of the patients that were on immunotherapy, especially daratumumab, did not really mount a significant response. And in those patients, booster shots are definitely highly recommended.
Is there a way for patients, for myeloma patients, if they're concerned, if they've had the vaccine and they want to find out if they've actually had a response, is there a way for them to find out?
Yes, so right now there are certain labs where you can go and get the PCR test to see if you have COVID or not, or the antibody test, but then they can also do titers. So you need to talk to your doctor before you do this, because you need somebody to guide you and know that if you have the titer, what does that mean? Not having titers doesn't necessarily mean that you're unprotected. We have seen cases where there aren't antibody titers and people are not getting sick, and people who have titers and still get sick. So we are still learning as we go. So it's always important that if you are interested in knowing what your titers are, discuss it with your myeloma doctor and see what to do next.
And in fact, we are doing now a study with the MMRF, with the Cure Cloud, and our work on Promise and P-Crowd, where we enroll everyone on something called IMPACT. And IMPACT is actually asking the question, not only antibody titers, but also your immune system, the T cells and the B cells, are they part of that response to the COVID vaccine, and how are you doing? So it will be from early MGUS and smoldering myeloma to active myeloma, everyone before your vaccination and then after your multiple steps of vaccination. What is your immune system? Not only antibody level, which is the titer, but also the cells, the immune cells, and how are they responding. And hopefully that data will come back immediately and we can give more information to our patients.
Yes, that's a really important study. So hopefully we'll be able to fully enroll that very soon. So that's great. So Irene, what are you hearing from your smoldering patients with regard to COVID, and what can you tell them about the impact of COVID and the vaccines, in the smoldering setting?
Yeah, so it's an important question because we just heard about multiple myeloma and the therapy, and we know that cancer patients may have problems, but then so many people are walking around with precursor conditions, MGUS and smoldering myeloma, and they ask the question, what about me? How is my immune system? We had done a study previously where we looked at the immune cells even as early as MGUS, and we found that the immune system changes as early as MGUS. So we don't know whether a patient with smoldering myeloma will have a perfectly healthy immune system or potentially an altered, a changing immune system that may look more like myeloma. And that's why we're doing the IMPACT study, which is asking that question. Should we add more information for smoldering myeloma and MGUS? Can we understand better your immune system and response to COVID vaccination? Especially as we're treating patients now with smoldering myeloma. We're giving daratumumab, we're giving many of the therapies that we have now in active disease in the smoldering setting. So all of this hopefully will be released soon. Hopefully we will have answers to everyone. But until then, again, be part of the study because you are the active participants. You are the one making this research happen and making us get those answers much faster, as well as, of course, be careful with yourself and with others. Hopefully you're all vaccinated, which is very important for us, and hopefully everyone will get the booster soon, and then just be careful with yourself when you're going out and you're being exposed.
Excellent. So, today has been a really exciting day at the meeting, and we've heard a lot at the beginning of today's meeting about immunotherapies for relapsed refractory patients and how promising they are, the CAR-Ts, the bispecifics. We've heard really great information for smoldering patients in some of the sessions today, and the hope for them as well, and new therapies coming down the pike. And for COVID, it sounds like we still have a ways to go before we can really answer a lot of questions, but we are doing studies and we are getting there. So we will have some answers for patients, and we're all hoping that soon this will all just go away. Thank you so much. On behalf of the MMRF, I'd like to thank Dr. Ghobrial and Dr. Rodriguez for joining me today during IMW. I'd also like to thank everyone watching this update. And finally, I'd like to thank our sponsors, Janssen, Karyopharm, Oncopeptides, and GlaxoSmithKline for sponsoring these daily updates. If you have additional questions about what you've heard today, I encourage you to call our MMRF Patient Navigation Center at 1-888-841-6673, and you can speak with our patient navigators, and they can help you with any other questions you might have. Thank you for tuning in today, and we'll see you again tomorrow.